Hello, welcome to the California Telehealth Policy Coalition Legislative Briefing, Telehealth Policy for a Post-Pandemic California. My name is May Kwong. I'm the Executive Director at the Center for Connected Health Policy. A little bit of background on the California Telehealth Policy Coalition. The coalition is made up of over 100 statewide and national groups interested in advancing telehealth policy in the state of California. Center for Connected Health Policy acts as the convener for the coalition, and we provide the public with information and educational resources on telehealth policy, as well as weighing in on telehealth policy recommendations made through legislation and regulation. If you are interested in joining the coalition or would like more information, please see the webpage on the CCHP website or reach out to CCHP staff. Today, we would like to thank our sponsors for this webinar, the California Healthcare Foundation, the Center for Connected Health Policy, and ROE. With their generous support, we were able to bring this legislative briefing to you today. Purpose and key objectives for today's webinar is to provide an overview of state and federal telehealth policy currently, also to discuss stakeholder perspectives and the impact on patients regarding telehealth, and have a panelist discussion on ongoing considerations and next steps for the state of California. We hope to answer key questions about existing and proposed legislation, as well as the future outlook for telehealth in the state. Our session today will be moderated by Diana Camacho from the California Healthcare Foundation, and our panels will include Dr. Anaya from UCLA, Sarah Hesketh from the California Association of Public Hospitals and Health Systems, Rebecca Picasso from Blue Shield of California, Carrie Sanders from the California Pan-Ethnic Health Network. Before we go to our panelists, I would like to give you a brief overview of the current status of telehealth policy, both on the state and federal level. As most of you know, when the pandemic hit, federal and state policymakers moved quickly to make temporary changes to telehealth policies to encourage the use of telehealth, which was really a very useful tool during the pandemic. Faced with a highly infectious disease, the use of telehealth probably saved countless lives, or at least prevented further spread of infection. As you can see, this is a very high-level 100,000-foot overview of some of the policy changes that occurred both on the federal and state level. And you see some similarities as far as like what issues were touched upon both on the federal and state levels. Issues such as what providers could provide services, what services would be covered provided via telehealth, and what modality was used. However, there are some particular issues that were in the jurisdictions exclusively on the federal level or on the state level. For example, on the federal level, the prescribing of controlled substances is controlled by federal statute, whereas on the state level, we saw really licensing issues being taken care of there. However, the question right now remains, what is going to happen next? These were all, for the most part, temporary telehealth policy changes. What will be made permanent? What will stick around after the public health emergency? And currently, both policymakers on the federal and the state level are struggling with those questions, and we see a lot of similarities as far as the issues and questions that they are working with. What we're seeing on the federal level, the trends that we're seeing there, as far as legislation is concerned, CCHP currently is tracking over 100 pieces of federal telehealth legislation. There's been a lot of reintroduction of bills to directly address the temporary changes, such as allowing audio only to continue, allowing federally qualified health centers to be distance site providers on a permanent basis. But we're also seeing some movement on the administrative level as far as what is going on with Medicare program and proposed regulations there that have been made during the physician fee schedule. We're also seeing on the state activity questions around payment parity as far as like how what will be reimbursed if a service is provided via telehealth and that type of modality that's being used to provide that service. A lot of questions on what to keep around as far as audio only. And also a lot of interest in like licensing of out-of-state providers and how to treat them when they are utilizing telehealth. As always, there's also a great deal of interest on data requirements and data gathering to really look at the use of telehealth and its effectiveness. And increasingly, we've seen interest on broadband, both on the federal and state level, because there was recognition during the pandemic that not everyone could access telehealth because of issues related to connectivity. So broadband, while always a concern for telehealth even before the pandemic, has really been elevated as a policy issue these past 18 months. Permanent telehealth policy changes. On the legislative side of things, we have HR 133, which actually was the Consolidated Appropriations Act that passed in December of 2020. It added rural emergency entities to be an eligible originating site on a permanent basis. But the more sort of interesting policy change that it made was to expand the mental health services in the Medicare program to not be impacted by the geographic limitation and allow them to take place in the home. Currently, before the HR 133 was passed, a limited set of services could take place in the home. One of them were mental health services, but it was it had to be done in conjunction with treatment for substance use disorder. HR 133 allowed all mental health services to take place in the home, and it did not have the geographic limitation, but it did have a caveat in that an in-person visit with a telehealth provider needed to take place at least within 6 months before the telehealth visit could take place. It also added additional funding for broadband. Again, we're seeing broadband receiving attention and funding to try to increase more connectivity for more people. On the administrative side of things, I mentioned earlier that there have been physician fee schedule changes. In this past proposal, the one that was issued in July and where public commentary ended on September 13th, there were significant changes made or proposed to be made for the Medicare program for 2022. Among those changes were allowing audio only to be used for the provision of mental health services. Now, there were a lot of conditions and caveats put on there, such as had to be for an established patient, there had to be consent from the patient, or the patient really had no access to live video, and other caveats in order for that to take place. But it was an expansion of the modality that be used, but it was only for mental health services. So it would not be for any other types of eligible telehealth services. Additionally, in the proposed physician fee schedule, they were going to redefine what a mental health visit meant for a federally qualified health center and rural health clinic. And underneath that new definition for a mental health visit, it would allow the service to be provided via audio only or live video, which is a significant change. So as most of you probably know, during the pandemic, FQHCs and RHCs were temporarily allowed to be distance site providers underneath the Medicare program. That is actually something that would need to change in statute in order for that to be made permanent. What CMS is proposing is redefining what a mental health visit means for these entities. So it is not putting FQHCs and RHCs as eligible distance site providers. It is just saying this type of visit they can provide via certain telehealth modalities and get paid their PPS or air rate. So, but that also means because they are not considered a distance site provider or not providing telehealth, those telehealth limitations, such as it needs to be in a rural area or it needs to be in a certain type of location, they do not apply for the FQHCs and RHCs when they are providing it via telehealth or audio only, and it's for a mental health visit. So there were some significant changes proposed in the physician fee schedule. They usually finalize the proposals in late November, perhaps early December if they're a little bit late, and they go into effect January 1st of the following year. What we're seeing on the state level, for their permanent telehealth policies on the state level in the Medicaid programs, and this was reflected before the pandemic too, all states in the District of Columbia were reimbursing for something via live video. Story forward and remote patient monitoring were a little less popular. There were about just roughly a little less, or maybe half the states that were doing some reimbursement for those two modalities. But before the pandemic, most states were not doing anything around audio only in their Medicaid program. As you can see now, that's changed. There's almost half the states that are allowing some type of audio only to happen and be reimbursed by the Medicaid program. So that's been a significant shift since the pandemic. What's also in the state jurisdiction are private payer laws. So there are 43 states in the District of Columbia that have some type of telehealth private payer law on their books. And they range from a state that says, health plan, you can cover telehealth delivered services if you wish, all the way to a state that says health plans, you shall cover telehealth delivered services the same way you would have in-person services. And by the way, you will pay the provider the same amount of money that you would have paid them had they provided it in person. And then all the other states fall in between those two extremes. Some of the examples that we're seeing as far as legislation on the state level, payment parity and audio only, licensing is becoming, again, a big issue that is out there, and like what to do with telehealth and licensing. Data requirements and having work groups established. So there's a greater interest on the state level of getting more information regarding telehealth in order to like help with the decision making. And then limited extension of emergency policy. So keeping around the temporary waivers for a period of time, probably to gather more of that data and information before a permanent decision is made. And updating existing private payer laws, sometimes perhaps updating the modality or the types of providers who can provide the services. What's going on in California. So this slide here really shows you the pre-COVID environment, what happened with the temporary waivers, and then like what's being proposed, what we know so far. So for those of you who may be familiar with this, proposals were issued by the administration in January with their January budget that proposed to keep around some of the temporary expansions, but there were also other proposals that may have looked like it would take the state a little bit backwards as far as their policies that existed before the pandemic. So there was some concerns of that happening and some concerns of like what was being kept around. So when the budget was finalized, there was agreement to approach this in a different way. And what that agreement was contained in AB 133, which was a trailer bill. And what they decided to do was, again, to extend the temporary telehealth COVID policies at least until the end of next year. In the meantime, the department will convene an advisory group to look at telehealth billing protocols, and then they would also protect the pre-COVID policy since there was some confusion over that. They specified that they would protect that. They were also going to start reimbursing for remote patient monitoring. On the previous slide, you probably noticed remote patient monitoring was not addressed pre-COVID or during COVID. And it also created the Children and Youth Behavioral Initiative, which incentivizes school-based telehealth. So California, in comparison to some other states, had really been lagging a little bit behind on school-based telehealth. Other bills that passed was AB 457, which expanded private payer protection. So it updated the private payer law to remove specific contract language, and it protected patient choice and third-party telehealth provider protections were also in there. Another trailer bill that was passed, again, as I mentioned earlier, broadband has become an increasingly high-profile topic and a lot of interest both on the state and federal level. SB 156, which would make a $6 billion investment in increasing broadband, particularly in that middle mile broadband infrastructure side of things, and also on the last mile support. I mentioned the DHCS stakeholder work group that has been in process. So the work group charge would be to look at billing and coding protocols, ongoing monitoring and evaluation, and utilization management. There was a very specific charge to this group. So it was not looking at the wide range and landscape of telehealth policy. It was looking at very specific issues. The group has met twice and they will meet a third time next week. These sessions are open to the public. While you are not a participant in the work group, you can listen into the discussion that is taking place, and that link and information is there. So, and with that, I am going to turn it over to our moderator for today's session, Diana Camacho. So Diana is a senior program officer at the California Healthcare Foundation, where she is on the Improving Access team, which works to improve access to coverage and care for Californians with low income. Diana leads CHCF's body of work on telehealth. Most recently, Diana worked at Kaiser Permanente, and she has additional healthcare and public health experience in the areas of public policy, language access, community needs assessment, and diversity, equity, and inclusion. So I will turn it now over to Diana.
Thank you very much, Meg. Thank you for having me here today. So here at the California Healthcare Foundation, we are pursuing many approaches to ensure that our state's 14 million Medi-Cal enrollees, 80% of whom are people of color, have timely access to high quality primary, special, and behavioral health care, with the goal of closing the gap between access to care for Medi-Cal enrollees and Californians with private insurance. One approach we believe must be the solution must be telehealth, and we have been supporting the adoption of telehealth for the better part of 15 years. This effort has included support for the important work of the California Telehealth Policy Coalition, which brings together stakeholders such as yourselves who share this vision to advance telehealth policy and payment. So while the pandemic has ushered in a new era of telehealth and the policies that support it, we believe that this work is far from done. Without concerted effort by policymakers, health plans, and the delivery system, we risk sliding back and losing the gains that we've made during the pandemic in telehealth. Even worse, we risk not only a golden opportunity to reduce the gap in access to care between Medi-Cal enrollees and those who are privately insured, we risk widening that gap. So with that charge, I'm delighted to be here today moderating today's panel with such a smart group of influential leaders in the telehealth space, where we will discuss how telehealth policy can support increased access and equity. So let me start by introducing our panelists. First is Dr. Yohualli Anaya, who is a clinical professor in the Department of Family Medicine at the David Geffen School of Medicine at UCLA. She received her medical degree and master's of public health from USC Keck School of Medicine. Dr. Anaya is a faculty expert for the Latino Policy and Politics Initiative and collaborates on research with the Center for Latino Health and Culture. Dr. Anaya is passionate about improving the health of healthcare of underserved and marginalized communities, and her research interests include healthcare disparities in vulnerable populations and minority communities, the application of research to promote policies and programs that address health equity, and physician workforce diversity. So excited to have you, Dr. Anaya. The other person I'd like to introduce is Sarah Hesketh, who is the Senior Vice President of External Affairs at the California Association of Public Hospitals and Health Systems, which represents California's 21 public healthcare systems that serve as the core of the state's healthcare safety net. Ms. Hesketh leads the CAPH's advocacy work that includes helping advance the organization's policy work and legislative platform. Most recently, she led CAPH state advocacy efforts to maintain telehealth flexibilities in Medi-Cal and increase funding to the public healthcare systems during COVID. Next is Rebecca Picasso, who is currently a principal program manager with Blue Shield of California and is responsible for virtual care and telehealth innovation. Her background includes 20 years in the healthcare industry with 12 years in telehealth program development, and she has extensive knowledge around telehealth billing, federal and state laws, contracting, clinic workflows, and program implementation. And last but not least is Carrie Sanders, who is the Senior Policy Director at the California Pan-Ethnic Health Network. Carrie got her master's from UC Berkeley. Prior to joining CPAN, Carrie worked as a policy analyst for the California Immigrant Policy Center, promoting pro-immigrant policies that address and respect the needs and contributions of California's diverse immigrant communities and their families. She's also worked as an assistant policy director for SCIU United Healthcare Workers West, representing over 150,000 healthcare workers in California, as the policy director for Services, Immigrant Rights, and Education Network in San Jose. Great. Now that I'd like to hand it over to each of our panelists to do a short introduction, including the impacts they see for telehealth on their constituents, how they are engaging in telehealth, and their thoughts regarding post-pandemic telehealth policy moving forward. So we'll start with Dr. Anaya.
Thank you so much for having me. Thank you, Diana. So I serve various roles at UCLA. I'm a primary care physician. I've got a pretty diverse patient population at both UCLA and our county clinic. I'm also on the core faculty for the residency program, and so I teach residents and medical students at both sites. I do hospital medicine as well. And then, within my research within health equity, I've partnered with the Latino Policy and Politics Initiative and the Center for the Study of Latino Health and Culture on research for telehealth in vulnerable populations, and including linguistically underserved populations. And so that's the lens and kind of expertise that I bring as a primary care physician and educator. And I think as a researcher also kind of allows me that bird's eye view as well as a view from the trenches. And so that's kind of the comprehensive perspective that I'm coming from. Serving these two populations and these two contrasting settings, right? At UCLA, we pivoted relatively quickly at the onset of the pandemic. And before the pandemic, we were already doing some telehealth, but we now have consistent video and some phone visits in our schedules. And then in contrast at the county, where within primary care, we will soon have, but don't yet have video visits widely available for our patients. And we've been doing either phone visits or in-person visits for primary care throughout this entire time. Some online messaging, But really, as we think about the post-pandemic telehealth policy, I think what we need is really thinking intentionally and thoughtfully about the approaches and consider and really addressing those various barriers that our populations are facing in telehealth care, grounding our approach in equity. Because if we are thinking at these higher levels and are not really, in the trenches thinking about how does this actually, is this actually going to happen, right, on a day-to-day for a patient? How are we going to make sure that a patient isn't assumed to not want to engage in telehealth? What are we going to actually do to mitigate that in that moment? Then we're going to lose out on and end up actually continuing to not bring in those patient populations. So, but I'll just kind of leave it there for now.
Great, thank you, Dr. Anaya. Sarah?
Good morning, and thanks for the opportunity to be here today. I'm going to give a quick overview of our systems and then share a little bit about kind of how they've put a lot of these new telehealth structures in place, and then share a couple of lessons learned that I think will influence our discussion going forward around the kind of post-pandemic policy. So CAPH represents the 21 public healthcare systems that include county-owned and operated, as well as the 5 University of California medical centers. Together, they serve about 3.5 million patients every year, majority of whom are on Medi-Cal or uninsured. A lot of our systems also operate, in addition to hospitals, very extensive outpatient services that include a number of federally qualified health centers. So we're in both the FQHC and non-FQHC space. I would say prior to the pandemic, many of our systems were doing very little telehealth. And so when the public health emergency first happened, there was this massive rush to just get something off the ground in order to prevent any disruption in care to our patients. That relied very heavily on phone visits. I would say since last spring, though, a lot of our systems have put in a number of different kind of efforts in place to achieve a number of kind of key critical goals. The first would be really establishing frameworks for scheduling appointments to ensure that patients are receiving the most appropriate modality of care. Patient choice is a lead factor here in terms of them determining what type of modality of care they want to receive. But a lot of our systems also have providers that will review appointments afterwards just to make sure that it's clinically appropriate depending on the modality that's been selected, and they'll work with the patient if they actually want to make a change there. In addition, there's also been a lot of work to optimize workflows to make sure that the same support and follow-up, both leading up to, during the visit, and after the visit, that takes place in person also happens virtually. So that includes all the coordination with the care team leading up to the visit, and all of the follow-up that may need to happen with specialty or behavioral health or what have you. And that means that a lot of kind of the time and resources that you would spend in an in-person visit is still pretty consistent and similar to a virtual visit today. I would also say that because many of the patients that our systems serve have challenges accessing video platforms, there's been also a lot of work and support that our systems have put into place to make sure that there's 24/7 advice lines or additional kind of tech support that can help patients get onto a video platform or just feel more comfortable accessing telehealth services, either video or by phone. And then lastly, similar to what Dr. Anaya said, many of our systems are in various stages of implementing video platforms. Some of them have them up and running, and others will likely have them up in the early part of next year. I'd highlight 2 key lessons learned that I think are really critical as we think about telehealth policy post-public health emergency. First is that the expansion of telehealth has been absolutely essential to connecting with patients in new and different ways and connecting with patients that maybe otherwise wouldn't have come in for care. We've been able to really reach out to patients and reduce no-show rates, reduce wait times, all sorts of things like that in terms of improving access to people that maybe otherwise would have come in, but have also been able to really touch patients that maybe otherwise wouldn't have come in for an in-person visit and connect with them in a much more consistent way. I would also say the other big lesson learned is phone has been absolutely essential connecting to our patient population and will continue to be so after the public health emergency is over. Many of our patients struggle with limited data plans or internet challenges, broadband, and so forth, and really, or just don't feel comfortable accessing a video platform. And so we need to continue to make sure that that modality is available, even while we try to address all of the challenges that I just mentioned. I'm going to end with two interesting patient examples that our providers had shared. One was a provider from the Central Valley that talked about how telephone had really helped manage their diabetes for a patient that they were serving. This patient often missed appointments due to transportation or financial issues, and having that regular touch point with the phone really helped both deal with blood sugar levels, but also prevent any challenges around adherence to medication. The second was a patient from Contra Costa that was a 62-year-old woman that had been in a massive car accident. She has chronic leg and back pain, mild cognitive impairment, lives alone and doesn't drive, and often reached out to the clinic very regularly for questions even before the pandemic started, and really has appreciated having the opportunity to have scheduled phone visits with their providers so she can kind of get all of her questions answered at the same time without necessarily having to come into the clinic. So thank you for the time.
Wonderful. Thank you very much, Sarah, for that background. I'll hand it over to Rebecca.
Hi guys, so I'm Rebecca and I lead virtual care and telehealth innovations for Blue Shield. So just to give you a little bit of background about Blue Shield, we were founded in 1939 in San Francisco, now headquartered in Oakland. We are a tax-paying nonprofit. We are also an independent member of the Blue Shield Association. We have over 4.5 million members and more than 7,500 employees. Blue Shield of California and its affiliates provide health, dental, vision, Medicaid, and Medicare healthcare service plans in the state of California. So as a health plan, we have insight, not on the patient side exactly, but we have insight into how our providers and our members use virtual care. So we did an analysis of our utilization data from 2019, 2020, and year-to-date through 2021. And our telehealth usage is actually on track to meet or exceed 2020 levels, which were up nearly 2,100% compared to 2019. And that's pretty huge. So Blue Shield of California believes that telehealth brings many possibilities, including the removal of barriers, and can help to decrease disparities, making care more equitable. Telehealth is an important option for our members as it allows them to access care in a way that's meaningful to them and provides increased access to care that might not otherwise be available. In terms of, I'm going to share a personal story just because in terms of post-pandemic, telehealth is super near and dear and important to me. In January of 2021, I was diagnosed with a life-threatening blood disorder, and I won't go into details, but telehealth actually was what saved my life. Pandemic, I wasn't going into the provider's office at all whatsoever. You couldn't pay me to go near a healthcare space. And so I had some issues. I had a telehealth appointment with my provider, and 2 days later, when all of that lab work came back, I was actually rushed to the hospital where I spent a month getting treatment and recovering. And so I just want to say that even though telehealth is, quote unquote new, it's not new. It's saving lives and it's saving real lives. And it's something that I will always advocate for, regardless of the reasons, regardless of the barriers. No one should have to document a barrier to care. It should just be accessible, and patients should be able to use it in a way that is meaningful to them. And I was able to use it in a way that was meaningful to me. So I appreciate your time, and I'm looking forward to the discussion today.
Thank you, Rebecca, and thank you for sharing your story. I'll next hand it to Carrie.
Hi, everyone. Hope you can hear me. Carrie Sanders, Senior Policy Director with CPEN. Really excited to be here today. The California Pan-Ethnic Health Network is a statewide health advocacy organization dedicated to eliminating health disparities for California's communities of color. We see telehealth as having a tremendous potential to improve health outcomes for those who have historically lacked access to medical care, including BIPOC, rural, and medically underserved areas. Really by connecting people to specialists and helping them to manage chronic conditions from home. In 2020, we conducted a survey of 1,600 racially ethnically diverse respondents, and they overwhelmingly reported satisfaction with telehealth, and an equal or greater satisfaction with telehealth services than with even with in-person medical care. And we know these findings are similar to others' findings as well, and points to the importance of expanding the availability of telehealth services, including audio-only services, which can really help to strengthen the integration of virtual care within our delivery systems. However, there are some important considerations in order to ensure that this longer-term shift to telehealth as a health lessens disparate access and improves health equity. And a couple areas, and I know we'll get into more detail in the conversation, but just pointing out, privacy concerns. A third of participants that we spoke with shared they lack a private place to be during telehealth appointments. And so, informed consent, audio only can sometimes help with this. We'll be talking about some of these different options, but these are considerations. Lack of access to telehealth technology, as others have mentioned, we know that continues to be a barrier for consumers to access, the bandwidth or technology needed, or even enough cell phone minutes to participate in visits. Several broadband bills passed this year, so I think there are some really important opportunities to educate educate patients about what is available and resources. And then two other just really quick areas: language access. 60% of LEP folks, limiting proficient folks, reported that they were, in our survey, were not able to receive care in their language. But of course, we know that it's available. And so, we need to really think about how we design our billing consent protocols to accurately track the use of this, of interpreter and assistive devices, et cetera. And then lastly, just jumping to consumer education and assistance. That will continue, I think, to be very important as we move forward. We know that this was something that was also flagged by folks that we spoke with who were just really new to using the technology and needed help to be able to figure out how to access these services. So yeah, we'll just stop there, but I look forward to continuing the discussion.
Wonderful. Thank you very much to everyone for their introduction comments. And I want to remind folks that they can put questions into the Q&A and we will pose them to the panelists. So I want to start our discussion with a topic that came up in nearly everyone's remarks, which is audio only, a fancy way for saying a phone visit. Given it's been the predominant telehealth modality, as Sarah mentioned, in many settings during the pandemic, and it's a hot topic in the discussion on coverage and reimbursement rates. So my first question is, what is the value and trade-offs of audio only according to your research, your practice, your experience, especially as it relates to access and equity? And maybe I'll start with Dr. Anaya, given her clinical background.
Thanks, Diana. Yeah, so the value is huge, right? I mean, as we've heard, this is how we were able to reach a huge population that we probably otherwise would have lost to follow-up. And that, a whole nother conversation for another day of the implications of the pandemic, right? But nonetheless, right, like we were able to reach our populations at the very least with that. But it is important that both providers and, at the higher levels at health systems are recognizing the limitations of phone encounters. And while telephone encounters can often be used in place of either an in-person visit, and I do this all the time, and I think they are very quite effective and satisfactory for patients. They have high satisfaction rates because they don't have to come in, right? Sometimes it's like, no, you do have to come in now. Like, I haven't seen you in however many months. Like, let's have you come in for an in-person visit. there are cases in which an audio only encounter doesn't satisfactorily replace an in-person or a video visit. And some of those cases would be in which a video visit would actually be sufficient, right? And so kind of recognizing those limitations should be what's driving us to ensure that we can actually provide equitable access for our patients. So, thinking about when care is provided at distance, if some of our patients don't have access to virtual visits, but only to audio only encounters, for whatever reasons those are, how equitable is the care that we are providing to them, right? When other populations have access to both, even within same healthcare systems. And so, it really does require that we ensure both on the provider side as well as on the patient side, their capacity for virtual visits. And so this is the issues of the tech capacity, right? The structural level issues, the structural determinants of health that we often refer to as social determinants of health, but really they're structural determinants of health, right? The access to the technology, meaning the devices, but also a device that has the sufficient speed of internet, and that our providers have those cameras and systems, but then also that within those larger structures that our systems are user friendly, right? That our patients can actually access them. So the majority of our patients in underserved populations do actually have a smartphone, but many of them don't have computer access. And so if our video visit platforms require a laptop, then we are excluding by definition a segment of our population. And secondarily, if a patient either doesn't have in what we call digital skills, but really just like past experience, right? Like if they are immigrants and they didn't have computer class here in the States when they were in elementary school or junior high school, then they haven't had that practice, and they're going to need us to provide them with that extra assistance. So that telehealth navigator, right, that can provide the tech assistance. And then beyond that, it's also not necessarily, so even if we offer, right, which we should be offering to all of our patients, that ability and opportunity to have either a video visit or an audio only, but if they say no, then probing, like, oh, why not, right? And for some patients, it really is just like, oh, I can't do that. Like, I just wouldn't be able to figure it out. Well, let us help you figure it out, right? So if they do have a smartphone, which a lot of them do have a smartphone, then let us help you figure this out. Let's do this together, downloading the application with them, helping practice with them, so that it's not either assumed from our own kind of implicit biases, or that it's not that it's left at the no, I am happy with a phone visit. And perhaps they're happy with a phone visit, and a phone visit is clinically appropriate and indicated, but perhaps we can do more for our patients. And it's really probing and going beyond that to help fill in those gaps.
Great. Thank you, Dr. Anaya. I think you really elucidated kind of, this is not so super straightforward, and there's not one thing that's better than the other, and it's really dependent on many factors. I'm wondering if other folks have anything to add on the value and trade-offs of audio only. And if you don't, one other thought I would, thoughts on how coverage and reimbursement policies could affect the use of audio only. Does anyone else want to jump in here? Maybe I'll start with Carrie.
Yeah, thank you. Just, I want to say, everything that Dr. Anaya said, we totally agree. I think, audio only is so important because many of our participants, as I mentioned in our survey, we found we're just simply not able to access the video technology. And Latinx participants in particular were most likely to report access to technology as a barrier. Whether it was not enough internet connection or bandwidth or enough cell phone minutes. So audio only, really helped to fill an important and critical gap for the populations that we work with. And it's also can be helpful to address privacy concerns. we met with and spoke with folks who work with young adults. We also saw in our survey that, some folks lacked privacy, living in large families. And so audio only actually can allow for greater privacy in certain situations than video only. And so, it's a very important modality that, we feel it needs to be included. That said, there may be instances where audio only is not preferred, which is why, we want to see careful delineation in the way that we're tracking utilization of, what is a video visit versus an audio versus, another type of visit. For example, on closer review of our data, one of the interesting points that we found is that folks were more likely to use telehealth for behavioral health visits. And we found a larger proportion use audio only for behavioral health visits compared to primary care visits. Yet, interestingly enough, satisfaction levels were lower for those who had a telephone visit in a behavioral health context. So, it just raises questions for us. We don't, we're still early in this experiment with telehealth, but these types of questions, I think maybe are significant to continue to explore, which is why we really want to make sure that, we're adequately capturing data on the use of these modalities and why patients are choosing to use one over another.
So I think a few of you haven't touched on it so far, but there's a tremendous interest and appetite for data on quality, health outcomes, and access, all related to audio only. In order to kind of answer this question of, is video higher quality than audio only visits and such? So Carrie, you mentioned wanting to look into efforts to collect more data on this front, but I'm wondering if anyone has, in their experience in their organization, collected any of this data or has seen any data related to audio only access, health outcomes, and quality. And if you haven't had any data, even anecdotal insights that can shed light on this question of, is audio only of lesser quality than a video visit? Maybe I'll start with Sarah.
Sure. So we've heard a few things from our members. First, I'll say that over the last kind of year and a half plus, I would say anywhere from 20 to 40% of our visits in primary and specialty have been telehealth. And again, vast majority of those have been phone. Some of the visits that have been reported from our systems of being the most useful in primary care have been what they refer to as talking visits. So changing medications, talking about chronic disease management concerns, those kinds of things, making changes to their medication, those kinds of things. On the specialty side, those have tended to be a little bit more on the video, particularly around dermatology, but there's also been use of, taking a high resolution picture and then sending that over to your provider and then having a phone visit. And then behavioral health, as Carrie mentioned, has been incredibly valuable. So we've gotten some pretty good information from our members about how much there's been a decrease in no-show rates, how appointment times have been reduced, and a whole host of kind of benefits on the access side. So I think we have a good handle there. On the quality, this is a big topic in the telehealth kind of stakeholder group, is that we just don't have good data on what's happening in the telehealth sphere. We don't have a good sense of how providers are tracking their visits, if they're documenting whether it's video or phone or what that looks like. And so we just need more consistency across the delivery system statewide. And a better, clearer picture of what that looks like. From what our members have shared with us, we have really heard across the board that there really has been some noticeable quality improvements, particularly around chronic disease management. Again, making sure that people are making their scheduled appointments and tracking what's going on with their chronic disease has really helped with blood sugar levels and diabetes and all sorts of, blood pressure, all sorts of things. And then I would also just add that it's also been really critical of getting patients into a provider in a regular period of time, which we think over the long term could have really big impacts from a quality and outcomes perspective. And I would also say healthcare costs, looking at long-term costs, getting people in when they need to be seen on a regular basis, and then preventing things from conditions from getting worse or issues from being delayed that could have been addressed on a more preventative, in a more preventative space. So
Yeah.
more to learn, but we've seen some good pieces so far.
And I think Sarah hit it right on the nail, right? So I think it's very much dependent on what the visit is for. I think for like chronic disease management, right? Like if I am adjusting your insulin, do we absolutely need a video visit? No, we can talk about what the necessary components to be able to make those adjustments and to actually potentially even be able to follow up with you on a more frequent basis while we are needing to uptitrate an insulin or a medication, right? And so you can have just fantastic quality if it's in the right setting. And I think this is what's kind of tricky about telehealth is that, as much as telehealth is its own bucket and we want to kind of say it can be a uniform kind of bucket, it's not really because it can't be a one size fits all when, of course, like I can't look in an ear via video visit or a phone visit, right? I can't press on a belly. I can have the patient do some stuff, and so it just kind of varies on what the purpose is and what the actual items that we are doing during that visit. And so I think that's where it kind of gets can be kind of murky, but the quality, I think it can definitely be there for the right in the right situation and circumstances.
Really helpful. Thank you. I'm wondering if anyone else on our panel has any other comments on audio only phone visits before we move on to another topic. Is there anything else anyone would like to share? I think we're all talked out about audio only. I'm sure the conversation is not even close to being over. But anyways, moving on to topic around utilization management. So this is something that's going to be a topic of conversation at the next Telehealth Advisory Workgroup meeting next week, which is really around the use of billing and utilization management protocols as a way to manage telehealth use. So I'd like to first ask, can someone give an example of what billing and utilization management protocols are? I don't want to assume that everyone understands these very technical healthcare terms. And then what are the implications for those? And do we already have guardrails in place to manage, the use of inappropriate telehealth? Or do we need to be doing something around this area? So kind of a big loaded question there, starting with what is utilization management and billing protocols, and then kind of what you see as the implications for that. So I'd like to start with Rebecca, so she can give us a bit of the commercial health plan perspective.
Yeah, so I may blow some minds here. Blue Shield of California actually doesn't have any specific utilization management protocols for telehealth. We treat telehealth the exact same as we treat brick and mortar in-person visits. So, obviously what we look for office visits and by extension telehealth is exactly the same. There really aren't, for us, there really aren't any kind of barriers or differences or changes. We do take into account, for example, telehealth only providers, so those that don't have a brick and mortar office. But for the most part, we look at them, exactly the same way. In terms of guardrails, it's a challenging concept, and I'll explain a little bit why. So we have our normal process, right? We have a special investigations unit. They have a process in place that looks for fraud. Most of how they look for fraud is things like unusual billing addresses, or all of a sudden, doing 50 telehealth visits in a 24-hour period. Like, how is that possible for one provider? Things like that. But where we fall short is in terms of in order to find fraud in, let's say, somebody billed a 30-minute visit and it was only a 5-minute visit, there's actually not really an easy way for us to identify that, short of doing manual visits or manual audits. And so it's kind of a hard concept to have those guardrails, and it's virtually impossible to detect fraud in that manner without doing a manual review. And so actually, in terms of a health plan, reviewing all of those claims is actually a lot more expensive than just paying them. We actually found that to be the case recently with COVID-19 testing. Some of the labs that we work with were trying to bill for an intermediate office visit level, like 30 minutes or more, when they were just determining if a patient needed to be tested, which is really a process that takes about 5 minutes. So we're still working on figuring out, looking at others' best practices and whatnot. But for the most part, in terms of how we're currently practicing that, it's no different than in person. We're just looking at data. We're looking at claims. We're, doing data is actually really big for us in terms of how we identify fraud, potential fraud. And so making visuals, which show outliers and things like that are definitely one way that we do it. But it's not any different than we would do for in person.
Thanks,
I would
Rebecca.
add also that, even if the practice is not different, similarly, the practice like in clinic, right? So a provider via telehealth or in person could be billing a 30-minute visit, even if it was only a 5-minute visit. And I don't think that there's like a telehealth specific concern there, right? Like, even though we talk about it, that can happen for an in-person visit, or it can happen for a telehealth visit. And I think that's an important point to make, just because we really like hyper focus on telehealth and fraud and overutilization. And so I think that that's not necessarily specific to telehealth.
Right. I 100% agree. And that's kind of where I was going with, our practice for identifying it or putting guardrails on. We don't. It's just like everything is just like in person for us. So yeah, it shouldn't, it's a tool in a toolbox. It shouldn't be looked at any differently than that.
While we're on the topic of kind of fraud and abuse, that was, a line of questions that I wanted to discuss as well. Do folks have any other thoughts or suggestions, in addition to what Rebecca already mentioned, on ways to monitor telehealth use and to prevent fraud?
So not necessarily like fraud, but more along the lines of utilization management. I have seen even when we bill our visits, we have a little reminder there. So for a phone visit or for an online service, is that, the guardrail of for an online, it covers a 7-day period, right? So you can't like keep billing and billing and billing. It's all for the 7 days, or similarly for a phone visit, right? So not to be using this particular billing code if there was an E&M service that resulted within the past, or that occurred within the past 7 days, or results within the next couple days as well. And so those are kind of examples of what we see and what really can be done for that utilization management, so that perhaps if sometimes patients because of the patient choice factor, right? Like I gotta work, I can't go in, and they think that an abdominal pain concern can be evaluated via video visit. And essentially, we do some evaluation, but it is limited. We decide that we still need to bring them in person for a physical exam. That perhaps there can be thoughts about, well, let's not completely void and null that assessment that was done, because there was an assessment that was done. There was time that was spent. There was the bureaucratic system level cost as well, right? But we acknowledge that an additional visit had to occur in this setting, and so perhaps now it's like a fraction that gets paid for that original online or video encounter when there needed to be a follow-up visit for that same concern.
Great. Thank you, Dr. Anaya. Carrie and Sarah, I'm wondering if you have anything else to add on utilization management, examples of, or the potential implications of utilization management and other billing protocols. Anything you'd add?
You want to go, Sarah?
Go ahead, Carrie.
I think it's been said, but again, just, really important, we think, to delineate the type of modality that's being used, whether it's, video visit, audio only, asynchronous, because, this is what will help ensure the robust evaluation of each modality that I think we all, want to see. And it should, and we understand that some visits are hybrid visits as well. So we need to really think about that. Many visits or some visits can morph from an in-person to a video. So we want to capture all that data. We want to be able to, look at that data by geographic region, by, race, ethnicity, language, other variables, and really, get a sense of not just utilization, but also, patient experience of these different, types of services. And so, I think as part of the billing protocol, we've been talking about, documenting in the patient record the reason for the use of the modality, which we think is also really critical because we want to make sure that it's not because of, technology limitations or that it's actually patient choice. And it's not a network adequacy issue, but again, patient choice. We think patients should be allowed to, with their doctors decide if they want to use telehealth services, but we just want to make sure that there's patient education, informed consent, and really good tracking and monitoring of the use of these services to make sure that, it's being done fairly and the patients, understand the decisions that they're making.
I think the only thing that I would add, because I agree with all of that, is that the department, particularly in the Medi-Cal space, has quite a few tools at their disposal already to look at potential misuse in terms of care delivery, whether that's audits or consumer complaints or just trying to assess outliers. And I think the same should be true for telehealth. We should be looking at potential concerns across the system, whether it's in-person telehealth or what have you. I think from a telehealth perspective, I think we also just have a little bit of caution of not getting too far ahead of ourselves of potentially imposing other restrictions until we know a lot more about what's going on. Like, let's use all the tools we have available and then see, once we get some better data on what's going on, to see if additional approaches are needed so that we don't have the opposite problem, which is actually imposing restrictions on how patients can access telehealth until we know what we're trying to address.
Good point. Thank you, Sarah.
I think if I could just add one more thing to that, one more thought. Part of the department and others being able to look at telehealth utilization and outliers is making sure that modifiers and place of service codes are used universally. And so that is definitely a recommendation that I would make to the Department of Healthcare Services here in California, especially, like, for example, and not to pick on them, but FQHCs and RHCs bill differently. They actually bill very similar to as if it was in person, if not exactly. And so it's hard to see that utilization. And so not even just taking out the fraud, the abuse, the all of that, just having that data is super, super important. And if they're not coding correctly, or if we're not all coding in the same way, I should say, then how are you actually going to be able to utilize that data and have it be meaningful? There's a lot of data missing.
Yeah, and I think that speaks to the point. It's a big topic in my passion in telehealth around equity, right? And we're not going to be able to understand those equity issues until we have more data that's reliable to do that. So I want to pivot the conversation to equity. I think we've all seen evidence and we've talked about the potential for telehealth to improve access to care, but we've also heard concerns related to disparities in access. I think, Carrie, some of the work that you highlighted is kind of alludes to that. So I want to first, maybe I'll start with actually Carrie, and I'll ask you, I know your organization has worked a lot on the experience of Medi-Cal patients related to telehealth. Anything you want to share on their perspectives and the implication that any new policies around telehealth or restrictions around telehealth could have an impact on equity?
Yeah, I think, and maybe this goes a little bit back to some of the guardrails here. I think, California has current guardrails in place, DHCS, to require, that practitioners are licensed in the state, have an affiliation with the local practice, are registered with DHCS. And, we think that's really important to ensure that, if there's an issue or a problem, that there's somewhere to go to resolve those issues, and there's clear, enforcement there. we understand, that I mean, there may be exceptions, and there's obviously a tension in rural communities or other areas where there may not be, as big or great access to specialists. And so in those instances, it's really important to monitor, to make sure that we have a sort of a carefully defined list of specialists that can, that beneficiaries can access through telehealth, and real clarity around, like, for example, if we're talking about behavioral health providers, are we talking about psychiatrists? Are we talking about, what specific specialists are we talking about? And that list really should be, curated and updated regularly to reflect changes in, workforce in California, including, the availability of bilingual providers, because we know that continues to be an issue. So we want to make sure that, consumers have access to and can still access, in person whenever they want to, or where they, if that is their preferred mode, and that we're not, kind of using telehealth to say inappropriately meet some of our network adequacy standards in the state. It's really important that we, continue to uphold those. And then I think lastly, we, sorry, as part of this, we want to make sure that nothing is lost when we think about care coordination. We know, with CalAIM, that care coordination, care management, there are new requirements. And, we want to understand, we want to make sure that there are clear protocols and workflows for referrals to in-person providers, or for clinical care, or, integration of care, and that people who have health-related social needs are still, able to get those types of local referrals that are so key to ensuring that they can access care. And finally, just really making sure that we're also tracking when requests are put forward for interpreters, for other assistive devices through telehealth, to make sure that consumers are actually getting the assistance that they're asking for, which they may be, they may be more able to get in person than through telehealth. We don't know. So we want to make sure that, there's nothing lost as we, move between different technologies and devices.
Thank you, Carrie. I'd like to open it up to any of the other panelists. I know you've all touched on equity in some way, shape, or form, but if there's any finer points you'd like to make related to equity and how policies could affect equity and access to telehealth.
I don't want to be repetitive, so I'll just two kind of points in addition to what I mentioned. First, the ability of thinking about how policy might be able to influence the actual that user-friendly system, right? So, when we are adding on our video visit platforms, when we are contracting, are we making sure that these systems are user-friendly, that they have been tested in vulnerable populations, in LEP populations, that they're going to be accessible and not in more than just English, right? And so, what kind of requirements can we think about there to ensure that we really are serving the populations that we are intending to be serving with these systems, right? And potentially even pulling in some of those tech giants and partnering to try to really tailor our systems, and or maybe creating more uniform systems so that whether it's in one healthcare system or another, it's an interface that is similar between systems, perhaps in that way, less barriers for patients to need to learn a new system, need to download a new app or whatnot. Also, the issue of email access is a big thing also for immigrant Latino populations, LAP populations. So while a lot of them have smartphones, a lot of them don't have email addresses or don't access email regularly. And so if our systems require for them to be going into their email address to access a video visit link, or if it requires them to even register with an email address, we can bet that it's probably not going to happen. And they're going to keep saying, no, I'm okay with a phone visit, right? And so, and that's going to not only create barriers for our patients, but really also create costs for the healthcare system. If instead of being able to do a quicker video visit with them, they end up having to come into the clinic for something that we could have done a video visit for. And so not forgetting about things like that, right? Like, again, it's beyond the device, it's beyond the broadband, but even those small things of they engage via text messaging, they engage via WhatsApp. So can we send links via the media that they are already using? Similar, how Kaiser does, right? They receive their text message and then they can click on a link. And so how can we bring those practices into our different healthcare systems? And then the last thing I'll say, and I did briefly talk about this, so I won't belabor the point, but the administrative burden of making sure that a visit is going to be successful is quite large for healthcare systems and offices that are serving underserved populations. And so there has to be some sort of policy level funding support for telehealth navigators. And so that equitable reimbursement really does mean that an insurer, a payer, is compensating for that rate is incorporating and taking into consideration the ongoing costs that have been added now, and specifically to be able to provide access to our most vulnerable patients.
I'd just like to add that from a health plan perspective, one of the things that we are trying to be very cognizant of when setting up new virtual care and telehealth programs from the health plan is utilizing things like single sign-on, so that, like Dr. Anaya said, they don't have to necessarily register for this program with an email address, but any information that we have, or if they have an account, they are able to access the things that we offer via single sign-on. And so we're also trying to make sure that in terms of access, that we are not creating barriers as much as possible. App fatigue is real, right? Everybody's tired of the 50 million apps. And so wherever possible, single sign-on is a blessing.
I think
Really
the only thing I would add from a policy perspective, and just want to acknowledge that California's made a lot of progress on this already, is that at the beginning of the year, we were having a debate on whether or not there would be telehealth, yes or no, and then what the payment would be for that. And so I think we've made significant progress here in already setting a playing field to where telehealth will be accessible, regardless of what healthcare delivery system you're in, regardless of whether or not you're accessing phone or video. And so now we're in kind of the next chapter of like, how do we then address connectivity issues? How do we then make sure that we're providing the most appropriate patient-centered care that we can, and then continuing to find ways to connect with our patients. So we've made some progress, and I feel like now we're on to kind of the next chapter, which is still really important, but want to acknowledge the first one.
Good point. We've come a long way. And I want to appreciate the points that several of you have made on building in equity and culture and language and digital literacy into the implementation of telehealth, not as just a policy issue, but as an implementation issue as well. And to one of the points, Dr. Anaya, you made about resources to support, say, like tech navigators, a question that I got from the audience was, are there any policy or advocacy efforts that increase funding to healthcare providers to improve their telehealth infrastructure, especially FQHCs? So anything that folks want to note for that question?
At this point, I think it's really just been like grant-based funding. And so again, just kind of speaking to the need, right? Like this needs to be, and at all levels, not only needing to come from the like federal level, but from the health systems themselves, from the payers themselves, so that we can really address those issues and be able to support our providers. Because it's in addition to supporting our patients, it really is supporting the providers and the offices, so that we can, in fact, build that infrastructure for our patients.
Go ahead, Sarah.
I was just going to say, from an FQHC standpoint, the one addition that I would make is this is an additional payment, but there is an effort going on in California right now to create a different kind of payment structure for FQHCs that would convert a kind of per visit volume-based payment to a per member per month. And that would kind of a capitated arrangement. So that would allow for a lot more flexibility in how FQHCs want to invest in the types of care that they provide. So they wouldn't be reliant on that touch with that in certain physician. And so you could potentially invest in telehealth navigators, community health workers, a whole host of other kinds of providers that you wouldn't have been able to bill for in the past, but then will fall under this type of payment reform rubric. So it's not additional funding, but it could still provide some resources in the same way.
And if I can just piggyback on that, I think others have said it so well, but you know, I think if we think about, you know, payment as the state is thinking about and capitated payments, really, it's really important to factor in all of these different aspects of care. And, you know, as we've been thinking about our priorities are really about ensuring that, you know, for example, we know that California is getting ready to implement a new community health worker benefit. How can we make sure that, you know, community health workers who can also help to provide some of these services are adequately factored into the provider payments, into this, you know, important patient education that Dr. Anaya talked about, and assistance in using technology. And it also, you know, it also includes, you know, medical assistants who, for example, you know, even though there may not be an office visit, there still are many, many touches that are required to provide good patient care, whether it's, you know, email, checking in, you know, getting the reminder from Kaiser, you know, on getting, coming in for your test, but as well as other administrative services and a whole host of services that, you know, may not be like what we think of or what are billed traditionally or thought of as clinical care, but are part of the full patient experience. So we definitely don't want to lose that. And, you know, again, I think as Dr. Anaya and said, this is a way to ensure cultural and linguistic access to care, that we're not losing that really important, you know, patient touch that will ensure that people can get the care they need.
Agreed. And if I could just add on to that for a second. So one of the things that Blue Shield has done is research on the voice of the customer, voice of the member for us. And one of the things that our members are really speaking up for and really advocating for is relationship-driven care, but not just relationship-driven care with their providers. It's a whole team, right? It's the nurse, you know, that I see constantly. It's the, you know, the PA or the registered dietitian or the physician or whoever. And so I feel like that, yeah, as we move forward and we're looking at payment and we're looking at policies, that whole care team really should be accounted for, especially as we start looking at value-based payments, because that's what, at least at Blue Shield, that's what our members are saying they want. You know, we want a relationship and we want relationship-driven care.
While we're on the topic of value-based payments and alternative payment methodologies, I'm wondering if anyone has any, I mean, we have a bit of a runway to that, right? You know, APM is a little bit out and we're moving towards value-based in many different ways. So I'm wondering if folks have any thoughts on an interim approach to ensuring telehealth is, you know, supported until we realize the full potential of APM models and value-based care. Sarah, do you have any thoughts on that?
Well, we've got telehealth payment kind of already, the current state budget has telehealth from a financing perspective and Medi-Cal through the end of 2022. I'm hopeful that the governor's proposal in January will include a continuation beyond that time period. So that'll at least hopefully address the payment provision of actually providing the visit itself. And then to your comment around kind of what do we do with the support that's needed, I do still think there's a longer conversation there. I mean, the alternative payment program for FQHCs is voluntary. So we don't expect every FQHC to participate in this once it goes live in 2023. And so there's going to need to be a variety of approaches, not only for FQHCs, but for other large Medi-Cal providers about what that support system looks like and how we are identifying what the needs are for our patients to be able to connect to telehealth, whether that be audio or video, and then making sure that they can access whatever modality makes the most sense, both for them, but also for the type of visit that they're trying to get. So the short answer is I think there's still more work to do. APM will help, but there's still more work to do.
Always. Thank you. And I have a question from our audience that's kind of related to equity in a way. Is there any data on the quality of care for different age groups? For example, children and seniors, and also for children, would there be data collected for their patients or the minors involved if you were collecting some of this information?
I don't know that I can, speak specifically to that, but what I can say is that in the stakeholder advisory group that, we have been asking California and DHCS to provide, more data on utilization of telehealth services and to stratify that data by, race, ethnicity, and also, age. Age was definitely something that came up, and geographic region. And it sounds like they, do have the capacity to do some of that stratification. So I think we're starting to see some of that data, but would like to see more. And so I think I would just kind of echo the question and say, I think it's a great one, and we would like to see as much, data as there is available so that we can get a more accurate picture of how these different populations are being served.
And I'll add in some of the programs that my organization has funded. It's not a quality. I don't have any quality data to state, but we are seeing, greater utilization for adolescents and children of telehealth. And there's hypotheses behind that. Maybe families with younger parents have more digital literacy or use of telehealth, but there is some early figures I have seen that have shown some higher utilization rates for the younger kids and adolescent population. Okay, I'm looking at our questions from the audience. I'm totally going to butcher this because I don't know what all these acronyms mean, but maybe someone else does. Currently, CMS includes NPP plus physician equals total visit time. Is this the same for BCBS and other pairs? I'm assuming they meant Blue Shield, Blue Cross, maybe in that acronym. No, Rebecca, you want to take that?
Yeah, so I can't answer for Blue Shield, Blue Cross because I'm Blue Shield of California, just stating that right there. But Blue Shield California follows CMS policies. So that would most likely be the case. I'm not necessarily prepared to answer that definitively right this moment, but that would most likely be the case.
Great. The other topic that we've touched a little bit on, but I just want to make sure that folks have nothing else to add on this, is around patient choice. And that has come up as a key principle for DHCS. I know I was on a visit the other day where I got to choose between a phone or a video visit, and I was like, ooh, this is exciting. So I want to know if folks have any thoughts regarding ways to protect both patient access and choice in telehealth if they haven't already. Any other points they'd like to make on that?
I just want to say from a health plan perspective, again, in also standing up virtual care programs or telehealth offerings, we want to preserve, member choice, right? We want members to be able to access care in a way that is meaningful to them. And so whether that's accessing in-person care, whether that's accessing virtual care, whether that's accessing, audio only, whether that's asynchronous modalities, I mean, it doesn't matter. We want to make sure that our patients are able to access care in a way that is meaningful to them. And I know that in terms of policy, there's been a lot of talk and a lot of what was it, AB 457? I might have it wrong, but that just recently passed that is intending to, again, protect patient choice. And so while I would say that I love that the legislators and policymakers are looking at protecting patient choice, I would also encourage you to make sure that in looking at protecting patient choice, that you allow payers and organizations to still provide that choice.
And Diana, I guess I don't want to be repetitive, so apologies, but I guess a couple things that I think are really important is, again, education, and that there are really strong consent mechanisms. So when I say education, not just patient education, but also provider education. I think there could be an investment in a public awareness campaign that could really, help to make sure that people understand what their rights are, and just making sure that consent is available in different languages and formats that are accessible for people with disabilities, Braille and large print font. We know that, consent documentation already exists and is a part of provider practices for patients with chronic conditions enrolled in certain programs and benefits. And so, and in those instances, there are annual and biannual reviews. And the same could be integrated or incorporated for patients more broadly who are using telehealth. So I think some of these workflows and protocols currently exist and are worth looking at to see where we could perhaps use these to ensure that there really is informed consent. That said, I think we do support, very supportive of patients being able to choose. We just want to make sure that they know what their choices are. I think you're muted, Diana.
Here we go. We are nearing the end of our panel time, but before we do that, I want to check in with folks to see if there's any other thoughts or important topics to highlight for policymakers that's essential to telehealth policy going forward. Anything that you think is getting lost in the broader conversation?
I'm going to say it just because it's super important to me, is FQHC and RHC restriction removals in terms of telehealth. I feel like that's getting lost, or it's getting more complicated. And FQHCs and RHCs provide care for some of the most vulnerable in our state, and making it more difficult to provide care, whether that's telehealth services, whether that's in-person care, whatever it is, really is doing a disservice to that patient population. And so I would just encourage policymakers to look at the restrictions that are in place in terms of FQHCs and RHCs, and maybe hopefully attempting to broaden those and make it easier for them to provide care to those patients.
Thank you, Rebecca.
To piggyback off of that, sometimes in telehealth, we focus on that conversation around like quality or utilization management or fraud. But I think we also need to kind of assess our telehealth systems on measures of equitable access, right? And that can be an additional measure that we're looking at and may add to the conversation about how we are doing with telehealth and reaching our patients.
Great. If no one else has anything else to add, I just want to thank you all for your insight and your passion on this topic. And I'll hand it back over to May to wrap us up.
Thank you, Diana, and thank you to our panelists. Let me just share my screen very quickly here. So once again, thank you to our moderator, Diana Camacho, and our panelists, Dr. Anaya, Sarah Hesketh, Rebecca Picasso and Carrie Sanders for a really informative, educational, and thought-provoking discussion today. I'd also like to thank our attendees for attending this particular webinar. And a couple of reminders. So if you are interested, the California Telehealth Policy Coalition, it has its annual meeting on November 2nd. You can, it is open to the public. You do not have to be the coalition member in order to attend. We'll have some more discussion regarding telehealth policy and what to look forward to in 2022. Additionally, I'd like to thank our sponsors today, the California Healthcare Foundation, Center for Connected Health Policy, and ROE for your generous support of this webinar and the coalition. If you have questions that you would like answered regarding the Telehealth Policy Coalition, please contact either me or Amy Durbin with the CCHP staff, or you can visit the webpage on the CCHP website. Once again, thank you to our panelists and our moderator, Diana Camacho. Hope everyone has a great day, and we will see you soon.